Okay. So I was going to pick up where we left last time. And the translation isn't very good. I think my accent probably throws it off. But anyway, we were talking about the best way. Well, can you see my screen okay?
Yes, it's good.
Okay. Um, we were talking about the best way to address stiffness and how if the load is too high, then that just causes inflammation and micro tearing, and it needs to be a small amount of stretch over a long period of time. And static dynamic splinting is the best way to achieve that. Do you guys use this splint?
I really don't use it, Mary. Pregunta Mary que si ustedes han usado este tipo de férulas.
The problem with it is that it's too much. It's pushes too much and it hurts and people can't tolerate it very well. So I don't use it very much either. Plus, they're kind of expensive. Um, so I really don't use them very much. I'm just showing people of what's out there. So the best way to stretch is to hold the digit in in a stretched position for a long period of time, and that's the total end range time. That's called tier. Um, and what that does is it causes growth. And there's been a lot of studies on it. One study by Ken Flowers, he had them in it 24 hours a day for 3 to 6 days for a PIP flexion contracture, and he had good results. So one way you could apply that is you could do like a cast. So you would see them and stretch them, get them in a stretch position, and then maybe apply a cast. If you see them on Monday, and then you would leave it on till you saw them again on Wednesday. So that would kind of work with that 3 to 6 days. Um, a systematic review, another one found that they really need to be in the stretch position for a minimum of 6 hours a day. So you wouldn't put someone in a splint for 6 hours a day, um, and especially if it's going to be in a position where they can't use their hand. So one way that you could achieve that is to have them sleep in it. And that's a really effective way if you're working on elbow extension or whatever you're working on to have them sleep in that position. And that'd be 8 hours. But of course, you wouldn't want them to sleep in a position that could cause tension on a nerve. And we know that if we flex the elbow greater than 90 degrees, then they're going to have tension on the ulnar nerve. So we would never have them sleep in a splint that would have them over 90 degrees of flexion. And of course, we wouldn't have them asleep in a position, any extreme positions that would put traction on a nerve. Um, Another great thing, the joint active splints, they're static progressive splints, and the patients can turn them up. They're expensive. Some people make them. Fewer people, I think, make them in the U.S. because it's just easy to use the other splints. So just some of the treatments for edema. Some people do massages, but again, I think that's temporary. Um, Elevation is great. So tell them just whenever they're sitting to try to keep their hand above their heart. Of course, when you're walking around, you can't walk around with your hand above your heart. So I tell people that every hour, put your hand above your head and make a fist 10 times, and that helps pump the swelling out. We give them gloves and co-band and different kinds of wraps. Circumferential splints definitely help get the swelling out. And the real thing that it just takes time for the swelling to come out, and really, several months. And kind of a rule of thumb I tell my patients, if they have swelling in their ring finger and they really want to be able to wear their wedding ring again and they're trying to decide when they should have it sized, I think kind of a good rule of thumb is after a year, it's probably as small as it's going to get. So you might want to wait a year before having it sized. So I use a lot of Coband. Um, tell the people to, make sure that it's not painful. And I think you should be careful too about giving Coban to anyone who might be taking a lot of pain medications because they could be too tight and they don't know it. So I think we have to, whether a splint or whatever, if people are taking pain medications, we have to really think twice with those people. Are you guys in Mexico, Central America, South America? Are you having problems with opioid abuse?
No. Pregunta
Not
Mary
really.
que si aquí en Latinoamérica o Centroamérica tienen sus pacientes problemas con opioides. Normally here, doctors don't give opioids to patients. It has to be like a very specific patient to give that kind of medication, mostly like cancer patients here in Mexico.
See, that's good. I think that in America, the doctors were really manipulated by big pharma, and it's caused big problems. And a lot of people have died, lots of people, and they're finally changing. But it's been a big problem. I used to give this sleeve out a lot, and like after a wrist fracture. But the problem with these is they fray and they're kind of expensive. And I felt like I was giving them a new one every time they came. So I don't use those very much. Does anybody use contrast baths where you have them put their hand in warm water and cold water going back and forth?
Pregunta Mary que si ustedes usan los baños de contrastes. I don't, Mary.
I don't think anyone does really. I think
No.
they've kind of fallen out of favor. There's not a lot of evidence that they're helpful. And there's not really consensus in the literature as far as uh, the protocol, whether you should be the same amount of time in the cold and the same amount of time in the warm. So I think people don't really use that very much. And when I was teaching one of these classes, I said that and someone said that when she had carpal tunnel and it really hurt, that she would get up in the middle of the night because her carpal tunnel really hurt, and she would just turn at the sink and she would turn on warm water and then she'd turn it off, then she'd do cold water. And she said it really helped. You can translate that if you want. Or do you want me to just keep going?
Yeah, yeah, yeah. It
Okay.
was clear. Yes.
Oh, okay. So I think the takeaway for me on that is that sometimes we throw things away and we say, that's not any value. I'm not going to do it anymore. But it just goes to show that you might say to a patient, if you're really hurting, you could try that. Stand at the sink, run cold water on it, then hot water, cold water, then hot water. And if it helps, it helps, and they'll keep doing it. And if it doesn't, they won't do it. But I think it just reminded me like I don't have to throw everything away because there may be someone that it's helpful for, and especially on something that's easy. It's free and it's not going to hurt anyone. Um, so just some pearls on ways to increase motion. And one thing that you can do is if you want motion at one joint, you can block it at another joint. So an example of that is if your MCPs are pretty supple, but you can't get very much IP flexion, what you can do is you could block the motion at the MP, and then when they make a fist, all the force of the uh, tendon will go to the joints that aren't blocked. And that's really the concept of casting motion to mobilize stiffness. And I don't know if you guys have heard of that. Have you heard of Judy Colditch?
About what, Mary? The casting motion?
Uh, Casting motion to mobilize stiffness.
Oh, yes.
Yes.
Pregunta Mary que si ustedes han usado o si han escuchado de lo que es el método de poner yesitos progresivos para la rigidez.
And that's Judy Colditch. Colditch, Judy Colditch. She's kind of famous, and that's her big thing is casting motion to mobilize stiffness. So she's saying, if she puts a cast here, then it's going to mobilize those joints.
Yes.
Um, Again,
Sí, y eso sería. Ujú,
if you're working on extension, have them maybe sleep in a splint for extension, and then work on flexion during the day because that's more functional.
ujú,
And people will sometimes ask if after a wrist fracture, you give them a wrist splint, and they say, "Well, do I have to sleep in it?" And actually, we tell people that they need to sleep in it a little bit longer because when you're asleep, you're not aware of where your arm is, and you could roll over and hit it. Whereas during the day, if you're sitting on the couch and no one's around and no one's going to jump on it, then you can take your splint off. But you should wear it when you're at the store. But remember that you might sleep in it longer because you're not aware of where it is and you can't protect it. So, and just another pearl, I know people, when they think about what position to splint in, uh, whether it's just kind of a resting neutral position or intrinsic plus position. And the reasons that we splint in the intrinsic plus position, one thing is if you have intrinsic weakness, then what muscle takes over? The extrinsic extensors. So the deformity tends to be this. So that's a reason to splint them in the intrinsic plus position. Also, if you have edema on the back of your hand, edema just grabs your extensors and pulls you into that position. So that's another reason to splint in the intrinsic plus position. Also, when your MCPs are in extension, your lateral collateral ligaments are laxed, and that's why you can spread your fingers when they're in extension. But when your MPs are in flexion, you can't spread your fingers. So when your MPs are in flexion, you've got those ligaments on stretch. So you would rather have them on stretch because if you splint in this position, they get tight. So those are all the reasons to really go for the intrinsic plus as opposed to just a resting hand position. Just some treatments for scars. Do you guys use the putty elastomer for scars?
yes.
So
Pregunta Mary que si usa los elastómeros para trabajar cicatrices.
it's all it is it's silicone,
Ujú.
and it's expensive. It's Autoform or 50/50 or the different brands that you get. It's fairly expensive. The other thing you can get are these gel sheets. And again, they're just silicone, but they're expensive. They're not very durable either. After a couple of days, you have to give the people more of them. So this is, can you see my arrow when I point at things?
Yes.
So this is the what you buy at the, you know, like Performance Health or one of those catalogs. It's silicone. So this is silicone too, also. And you can get it on Amazon and it's a lot cheaper. It's just silicone putty, the exact same thing as this, much cheaper. You know what else is silicone? Pure silicone? Caulk. The same thing. And if people are allergic to silicone, then they're not going to be able to tolerate this. And if they're not, then they can tolerate this. The great thing is this is so inexpensive. And if you're not comfortable putting it directly on their hand, you could put some tape down first and then form it. I think the disadvantage of this is it takes longer to set up, but I'm just trying to point out that there's always a less expensive alternative if it's not in the medical category. So some of the other treatments for, but well, part of the reason that we do silicone for the scars is that the idea is if you deprive the scar of oxygen, that it will promote lysis, and lysis is taking away, and synthesis is growth. So by putting the putty on there, you promote lysis, which is what we want to promote. Um, Another thing, and someone was talking last night about a scar, and it really had the EDC tied up. So I always have people, do the motion and I work on the scar, while they're exercising to try to get that moving. And the other thing you can do is electrical stim. If the person, if you're asking a person to do this, continually while you massage it, they can get tired. But they could do electrical stim and have that pull on it, and you can combine that with massage. And now those electrical stim units are really cheap. You can get them on Amazon for like $30. And so I'll tell people to just go buy one and put it on. And the EDC is one that's really easy to hit. And so while they're watching TV, they can be doing that. And every time they're tugging on that scar. Um, I think tape, I really like taping, kinesiology tape for scars. And the kinesiology tape, there's limited evidence on its effectiveness for scars, but it's not going to hurt anyone. And so I think, why not do it? And I do see that it helps. Um, this is a scar after distal radius fracture, and the scar is stuck. The flexor tendons are stuck in the scar, and so we were really working on that scar to get those tendons unstuck. So, if you're working with a wrist fracture and their wrist extension is pretty good, but then when you add the fingers, then it's really tight. Well, you know that those tendons are stuck in the scar. And again, if you have a scar from like a tendon repair on the dorsum of the hand, and that scar's keeping that tendon from pulling into extension and also keeping it from pulling into flexion, then you need to work on that scar. But if a person just has a scar somewhere randomly from from a surgery, and it's not, limiting the motion and you know, um, causing adherence that makes things not move, then, why are you working on that scar? And I think it's just a question to ask because I see therapists so many times just working, digging their, thumbs into scars, like a scar on the, ulnar side of the hand or a scar, at the elbow. And again, if it's not causing problems, why are you working on it? And just remember, if you had your appendix taken out, the doctor wouldn't say, "Oh, you need to go to therapy and have them work on your scar." You just because the scar's there doesn't mean you need to work on it. There needs to be a problem, a reason why, and just kind of keep that in mind.
Dice Mary que hay que
Mari,
considerar que muchas de las veces no todas las cicatrices necesitan trabajarse como arduamente. Obviamente se tiene que llevar un proceso en el posoperatorio en el que limites el crecimiento de la cicatriz, la inflamación, pero que si realmente es una cicatriz que no da problemas, no tienes por qué estarla trabajando constantemente.
Some people are using dry needling to mobilize scars, and I know a lot of your countries you can't use dry needling, and there's not a big body of evidence that it's helpful for scars, but I just throw that out there. Do you guys use these?
Yes.
And I've used this for, I don't know, 20 or 30 years, and it's just a snake bite kit. And you can get them at Walmart or any place in the camping section for like $10 or on Amazon. Um, If you buy them in a catalog, it's a lot more than that. And I always say now everyone's interested in cupping. Cupping's kind of a new thing, and you'll see a lot of physical therapists in your department doing a lot of cupping. But I always say we were doing cupping before everyone else was.
Mary dice que este es un, can you put the last one?
This one?
Ajá. Es un kit, ese kit es un kit de mordedura de serpientes o de insectos. Eso se consigue en lugares donde venden cosas de campamento. Y eso es lo que ella usa para la succión de la cicatriz.
Uh,
Rosa,
¿Sí?
mira, hay una pregunta acá en el chat, si se la puedes traducir tú, porfis, que es de Marianela. No sé si la ves. Dice, en cicatriz hipertrófica de 1 año, ¿dará resultado la punción seca?
Mary, someone's is asking if after a year in a hypertrophic scarring, can you use dry needling?
I've never heard a reason why you couldn't use it.
Ujú. Ella dice que no hay una razón para no usarla. Por ejemplo, yo sí uso punción seca para cicatrices, entonces en cicatrices hipertróficas sí se puede usar para hacer un proceso de inflamación nuevo y un proceso de remodelación nuevo. A comparación de una cicatriz queloide, ahí no se usaría la punción seca.
So why not try it?
¿Ah?
I would say try it. Give it a try.
Mary dice, úselo, denle oportunidad.
Another thing that people are talking about a lot now is vibration. I don't know if you guys use it. If you're followers of Allison Taylor, do you know who that is?
Yes.
She posts a lot of things, a lot of videos, and she loves vibration. Um, and the you can get them on Amazon. They're pretty cheap. And you know, the idea is you hit it on something, and then you can use this end. Again, it's not going to hurt anyone. You can give it a try. Um, Part of the idea is that the vibration goes to those signals go to the brain first, and they kind of the gate theory, they turn off the pain. People are using them on scars. So I think you're not going to hurt anyone, and why not try it?
Mary, I will show you what I use for the vibration is this one. They use
Oh,
it like for the Botox while they're doing the needling.
oh.
So I use this one too.
You turn it on? It has
Yes.
like a battery?
Uh-huh. And it will do the vibration by itself.
That's bad. That's a lot better. And
Yes.
did you get it on Amazon?
Yes, on
All right.
Amazon, and if you're in Mexico, and I think si están en México, en algunos lugares de Latinoamérica, también en Mercado Libre lo consiguen. Este es se usa para lo que es facial, se usa mucho para el uso del Botox, y de igual manera produce vibración. Yes, so it's very helpful.
Are you supposed to use that after you have Botox?
No, the doctor use it while they're doing the Botox. Like they're putting the needle, use
Oh,
it for the pain.
oh,
Yes, it's like a modulator for the pain.
oh, that's awesome. I'm
Yes,
buying that. That's great.
yes, it's
I
great.
love it. And it's,
Mari, Mari, I have a question. Um, how can we know in which moment of the score we can work with this instrument?
I mean, I think that's a good question.
Mhm.
And again, I would say, why are you doing it? And people, if you're working on a scar because it's painful, wouldn't the best thing be to just leave it alone if it hurts? You know,
Mhm.
When
I'm
it's
just giving my opinion, but I think the only reason to work on a scar for us is if it's stuck. If it's sticking, gliding of the tendons. But I think if it's painful or whatever, that's a reason to not do it. I know I'm the only person who thinks that, but I wouldn't spend time doing this on somebody's painful scar. I just leave it alone, let it calm down. But that's just my opinion.
Ok, Mary dice que para qué trabajar una cicatriz si está siendo realmente dolorosa y no está causando ninguna limitación o no hay ninguna adherencia importante, que es mejor dejar las cicatrices en paz. Y para la pregunta de desde cuándo se deben de empezar a trabajar las cicatrices con vibración, es hasta que el paciente ya no tenga suturas, que es más o menos a partir de la segunda a tercera semana y que no haya un proceso de fractura.
And maybe if you were going to do it and then follow that up with some exercise, and they could do the exercise better because you did vibration first, that would be a reason to do it. But we have to remember clinical judgment. I think it's so important, and how things are working for our patient. So this is just another picture of how the scar can really get that EDC stuck on the back. There were some articles about using iontophoresis for scars. And do you guys use iontophoresis?
I don't. Pregúntame, Mary, si ustedes usan iontoforesis para el tratamiento de cicatrices.
No one uses it anymore. And it's one of those things that everybody wanted to use and now no one uses. And a lot of insurances won't pay for it now. And the reason they won't is because there's not good evidence that it's effective. And also, when we bill in the US, we use codes, and the codes have different values. So, like the code for heat, you can't charge anything for that. And the code for ultrasound is maybe $10. But the code for Ionto is like $50. So even if an insurance pays for it, is it really worth that much money? And I think people just don't do it anymore. There was a study in the Hand Journal, and they did iontophoresis with vinegar. And in the study, they did the amount of vinegar in the solution was 0.5. Well, the vinegar that you buy in the grocery store, because people were saying, well, just go buy vinegar in the grocery store. The vinegar in the grocery store is between 4 and 8%. And this, in the study, it was 0.5. So it's a lot less. And tell me if you want me to stop, Rosa.
It's fine.
Do you remember when you were in high school, did you ever do an experiment where you put an egg in a jar of vinegar and watched the vinegar dissolve the eggshell?
Oh, yeah.
Yeah. Vinegar's highly acidic. It's so really, really harmful. And so you definitely, if you did Ionto with that, you want to do very small percentage. And the other thing is the Ionto, the electrical, you do a positive electrical current, which builds heat. And if you did something from the grocery store, a lot of times those are sugar based, and so they could cause burning. So I think there's a lot of reasons not to do Ionto for scars, and I don't think there's a lot of reasons to do it. But again, you have to use clinical judgment. Desensitization, of course, we do a lot of that. Desensitization for scars. If it's very sensitive to touch, you can have the patient, rub it on different textures and things. But again, I think a lot of those things you can tell people to do at home, and you don't have to spend a lot of time in the clinic on things like that.
Yeah, someone was asking what about the scarring that hurts when even like touching or rubbing something in the palm of the hand. And I was telling them that it's important to work first with the sensibilization before working manually with the scarring because you're only going to cause more pain and more inflammation.
I definitely agree. Yeah.
Ujú. Entonces, aquí hicieron una pregunta en donde dicen que qué pasa con las cicatrices que duelen al tacto y están en la parte de la palma. Eh, Mary también dice, es importante trabajar la desensibilización antes de empezar a trabajar manual o con cualquier otra cosa, porque si no, lo único que vamos a causarle al paciente es más dolor, más inflamación y el paciente va a dejar de mover o de usar su mano.
Okay. Oh, sorry. Okay. Here we go. I had these things opened. I thought it was going to be easier. I think I can go. Here we go. So how is that? Can you see that?
No. It's in half. You're sharing. I don't know why it's not complete.
Let's see. Okay, I'm going to go. Okay, I'm going to stop. I'm going to stop sharing
Yes.
and then I'm going to start again.
Okay.
Okay. Now can you see it?
Yes.
The other thing I need to do is get rid of this. Better?
Yeah.
Okay. So I was going to talk a little bit about tendinopathies. I don't know if you guys have talked about them very much. Vera has shared the curriculum, and so I was kind of trying to hit on some things that maybe you haven't already talked about. So, kind of talking about, I think the worst tendinopathy to treat is lateral elbow tendinopathy. And again, there's a lot of different names for it. And I think it's probably one of the most difficult things that we see. It's one of the most common conditions. It affects 3% of the population, and about 70% of the cases are work related. There are more than 40 treatments described in the literature, and counting. And every day, when you look on YouTube or you see things on Facebook, there's always some new treatment for lateral elbow tendinopathy. But there's no evidence in the literature or no consensus on what is the best treatment. And the one thing I think that's really important to remember is that after a year, they almost all resolve, and that's whether they have any treatments or not. So just keep that in mind.
Mary, someone has
Hola,
a question.
hola Mary.
See?
Excuse me. Yo tengo una pregunta. Bueno, antes de que pases al tema de las tendinopatías, bueno, en los casos bueno, de las cicatrices que nos acaba de mencionar, bueno, tengo la duda de que primero se debe trabajar el tema de la sensibilidad y ya después trabajar la parte de la cicatriz con todas estas otras técnicas de ventosas, de punción seca para remover, ¿no? O sea, las adherencias, o podemos trabajar de forma conjunta. Lo que pasa es que en algunos pacientes, por ejemplo, que han sido operados digamos, un caso de nervio, ¿no? queda muy, muy sensible la zona. Entonces, es muy difícil, digamos, trabajar eso, pero también queremos evitar la adherencia, ¿no? No sé cómo haría el trabajo en este tipo de casos.
She's asking about scarring. When you have a patient, that the scar is being a problem because of the addition of the fibrosis, but it's also hypersensitive. Like, how would you work that scar? Would you wait till it's not sensitive anymore, or you will do it like both at the same time?
I mean, I think it's exactly what you said, Rosa, how you're going to
Mhm.
start out with the desensitization, whatever small amount, whether you're doing it with cotton or just lightly rubbing something, um, and then go to, progress like that. But I think it's exactly what you said, Rosa.
Dice Mary que es como lo dije, que primero hay que trabajar en la desensibilización antes de empezar manual y empezar a inflamar o causar más dolor. Y también una parte importante es que si al inicio del tratamiento vemos que el paciente tiene muchos problemas con alodinia o dolor muy agudo, lo que se puede tratar es trabajar al paciente en una clínica del dolor, referirlo con un médico especialista para la clínica del dolor para que nos ayude a que tampoco pierda o perdamos nosotros la oportunidad de trabajar en un proceso agudo la cicatriz y que no se vaya a adherir más.
One thing that I feel like I've learned, it's taken me 30 years to learn, is to not hurt people and to tell people to respect pain. And I always tell them, pain adds up, so you hurt your hand and then you had surgery and you hate your job and your car broke down and whatever, and that all stacks up. It doesn't happen on the side. It doesn't, hurt my hand and my car broke. They all stack up. And so I just think it's so important. You got to turn that stuff down and not do things to hurt them more.
Dice Mary que es importante aquí respetar lo que es la escala del dolor, entender que cuando el paciente tiene mucho dolor, tampoco tienes que provocarle más dolor del necesario. Entonces aquí sí es como trabajar en conjunto de que si no está mejorando el dolor, pues entonces sí refieran al paciente con un especialista para dolor.
If your foot is sitting here and I accidentally hit your foot and you wouldn't even really notice and you wouldn't say anything. But if yesterday you dropped a brick on your foot and your foot was really hurting and I touched it the same amount, you would scream. It would really hurt because it's already hurt. So just think about like it's already really heightened, and what we need to do is calm it down and not do things to make it hurt more.
Ujú. Que si ya tenemos algo que duele mucho, lo que tenemos que trabajar es para relajar y bajar el dolor y no hacer que duela más.
So on
Ok,
okay.
gracias.
So on lateral, and I'll just call it lateral tendinopathy or lateral epicondylitis. Again, there's a lot of different names for it. But there are over 40 treatments described in the literature, but there's little evidence or consensus on what the best treatment is. And when you have a condition where there's not good treatments, it leaves the patient and the provider vulnerable to unconventional interventions. And one study found that over 50% of the continuing education courses uh, teach interventions that are not evidence-based. And I think we all want to get on that wagon. We see videos about needling or cupping or vibration, and we think, oh, we really want to try it. And I think it's okay to try it as long as we're not neglecting to do the things that are evidence-based. And keeping in mind it should be a small part of what we do. And also, if we do some vibration on someone and they come back the next time and they say that really helped, that was great, then we should do it again. But if they come back and they say it didn't help, then we should do something else. So just always using your clinical judgment. Nothing substitutes for that.
Es mucho de usar el ojo clínico. Dice que, por ejemplo, si tú tienes un paciente y usaste alguna técnica y el día siguiente viene y te dice que le fue bien, entonces puedes seguir usando esa técnica. Pero si el paciente refiere que tuvo más dolor o que le fue mal, entonces tienes que cambiar de método de tratamiento porque no a todos los pacientes le funciona lo mismo. Y es lo mismo en usar las técnicas basadas en evidencia de, por ejemplo, si vas a puncionar un tendón, pues que se haga de manera correcta y no negligente. Yo soy cero partícipe de hacer punción o electropunción en tendones si no tienes un equipo de digo, de ultrasonido, porque es más el daño que puedes hacer. I was telling them, Mary, that I'm not I don't agree to do like electro punction on tendons without using a US, you know, like to see where you're working through the body and where you're putting the needle.
Do you have ultrasound in your clinic
No,
that you can
no,
use?
I don't have it, and I want
Oh, okay.
one
Some
because
people
I want to
do.
do it. Yes.
Dr. Lalonde showed me this thing that you could hook to your iPhone, and it was maybe this big, and it would do an
Yes.
ultrasound, and you could see
Yes.
the image on your iPhone, but it cost $5,000.
Yes, that's expensive. So that's
But
why I'm telling them, like you said, it's neglected. Like if you don't have the ultrasound to do it, you can cause a lot of damage to another tissue if you don't have the knowledge to do it.
and I think again, just listening to the patient too.
Yeah.
If it works, do it again. If it doesn't work, don't.
Mm-hmm.
One thing that's
Mari, a question.
see,
In your experience, which is the best or the method that work best?
metal that works best.
In your experience,
What I don't I'm not sure.
¿Método para qué?
for treats epicondylitis.
Oh, she's asking what is the best method, like, or the one I've used that
Exactly.
works the best for the
Exactly.
tendonitis.
That's a good question. So,
Yeah.
so what is
Sorry
new?
for my English. Is
Oh, no. What is new in the treatment of lateral epicondylitis is clinical practice guidelines. And I'm going to share the article with you.
Okay.
But the clinical practice guidelines, what they do is they synthesize and they pre-appraise the literature. And so it saves clinicians time because you can read an article that says ultrasound is good. You can read an article that says ultrasound is bad. You can read an article that says corticosteroid injections really help. You can read one that says that they don't. So the great thing is when clinical practice guidelines, because they appraise all that literature and then they give you solid guidelines of what you should practice and what you shouldn't. And I'm going to share all that with you. But the fact on lateral epicondylitis is that there really isn't one good treatment form. It really takes time.
Mary dice que realmente no hay un tratamiento específico para las tendinopatías, que puedes tener el conjunto de varios y ver cuál le funciona a tu paciente, y eso es muy real. Una técnica nunca te va a funcionar igual de un paciente a otro, entonces es mucho el ojo clínico y de cómo va evolucionando el paciente para saber qué tratamiento ir teniendo.
And I think this is important. And again, this clinical judgment is we have to identify the right treatment for the right patient at the right time. And also when it's time to refer. So if we see a patient for a while and they're not doing well, then maybe it's time for them to see the doctor and consider an injection.
Es importante saber también hasta dónde son nuestros límites, saber que si el paciente tiene un tiempo en terapia y no va bien, entonces tal vez es tiempo de referir a ese paciente ya con el médico para que haga una valoración nueva, necesite infiltrar o algo por el estilo. Es mucho ojo clínico.
Can you see my cursor moving when I move
Yes.
it like that? So if you had a young worker, factory worker, who's came to you and their uh, elbow is killing them and they're having so much pain, for them, it might be like a lot of heat and tape and ultrasound and gentle stretch. And then if you have a retired person who, do you know what pickleball is? Do people play pickleball?
Yes.
It's kind of a
Pickleball.
new thing. Like everybody in the US, particularly retired people, are playing pickleball.
Yeah.
Love it. Yeah. So let's say someone comes to see you who's retired and they play pickleball, and the only time their elbow hurts is when they play pickleball. Well, your approach is going to be different for them. You're not going to do a bunch of massage and ultrasound and heat on them because it only hurts when they play pickleball. So maybe on them, you're going to teach them kinematic chain and you're going to teach them to not, you know, lead with a wrist like this to, and you might do more stability exercises. So just all, it's really why we went to school is, to use our judgment of I'm going to do different things with this patient, different things with this patient.
Ok, entonces sí es mucho de usar el ojo clínico y saber qué necesita cada paciente. No es lo mismo un paciente que es joven en una edad productiva y que es trabajador, a un paciente que ya es retirado y que sus actividades se limitan a ciertas cosas y sus dolores o sus padecimientos se dan por ya actividades que no son relacionadas a su trabajo.
How many times have we said, or how many times have other people said, I always give my patients the armband. I always do needling or whatever with these patients. And instead of saying that, we should start thinking differently and thinking, what's unique about this person?
Ok, dice Mary que debemos de empezar a pensar distinto porque cuántas veces no le hemos dado a los pacientes las banditas que son para tendinitis en vez de hacer un tratamiento a lo mejor diferente, un poquito más invasivo o menos invasivo, dependiendo de lo que el paciente necesite.
And I think most important is this sentence, just keeping in mind that many times they're self-limiting and that they're likely to resolve with little or no treatment.
De que a veces tenemos que pensar que el mejor tratamiento es muchas de las veces nada invasivo, o sea, un tratamiento no tan estricto.
And we shouldn't be seeing these people 3 times a week for 4 months, because I think that tells you what you're doing isn't working, right? If it worked, why would you have to keep doing it for 4 months?
Y dice que no, a este tipo de pacientes no los deberíamos de ver 3 veces a la semana por 4 meses. Eso quiere decir que el tratamiento no está funcionando.
This is just kind of a picture that shows the tendons. You guys all know that. Some things about assessment. I don't know if any of you have this thing, but it's called a algometer. Here, algometer. And you can get it on Amazon, but it's just an assessment tool. And you would push and record the amount of pounds that that they can take without feeling pain. It's kind of expensive. So one way to do an assessment of pain, especially for lateral epicondylitis, would be to do that and see how much, how many pounds they can before they feel pain.
Ujú. El ergómetro nos ayuda a medir la presión, por ejemplo, hasta qué tanta presión puede tolerar el paciente antes de sentir dolor. Y dice Mary que ese se puede comprar en Amazon, pero es en Amazon, Estados Unidos.
Another assessment that you can use for lateral epicondylitis is grip strength. So it can be just regular in the standard position. How much can they squeeze without pain? And then also people will do it in pronation, supination, and neutral, record those amounts. Again, it's just some assessment tools because you want to know, like, how can I tell if they're better besides the numeric pain rating? Yesterday you were at an 8, today you're at a 6. And those are good, but these are just some other ways that you can assess pain. Because with lateral epicondylitis, it's pain, right? It's not a range of motion problem. It's primarily pain.
Dice que aquí es importante hacer el enfoque de que la epicondilitis es como tal dolor, no es restricción de movimiento, es dolor.
These are some tests for lateral epicondylitis, Cozen's test. And I'm sure you guys all do that test. I do this one because people will say, my elbow hurts and the doctor gave me a wrist splint. Or their elbow hurts and I'm telling them stuff to do differently at their wrist and they're saying, no, it's my elbow. So whenever I do this and I resist elbow extension and it makes I resist wrist extension, it makes their elbow hurt, then they get it that the reason their elbow hurts is what they did here, not what they did here. Another test is the resisted middle finger extension test, but that's also a test for radial tunnel. But if you are doing any kind of needling or any kind of, trigger point things, resisting the middle finger is a good way to isolate that, the ECRB too. And this is Mill's test. I don't know if you guys are familiar with that, but so I mentioned before about evidence-based medicine, and more and more we're seeing clinical practice guidelines based on evidence-based medicine. But what we're finding is that people are not using evidence-based medicine. People are not practicing it. And again, I think Rosa mentioned before, the studies say it takes 17 years for something to go from research into practice. And really that's too long. But even therapists and even me, I'll admit it, we do some things that are not evidence-based. So I think some questions to ask yourself when you're trying to decide if you should use some interventions that have weak evidence, because again, we're using our judgment. We're trying to decide if that thing would help. And I think, of course, the first question is, is it potentially harmful? And so we're not going to do something that's potentially harmful, especially if it's low value. And I think that's something that Rosa was saying about the needling was, unless you really know what you're doing and you really know what structures you're putting into, it could be potentially harmful. So again, you have to really think about that. Another question to ask is it expensive? And is it expensive for the patient, but also is it expensive for the system? So like iontophoresis is, if your insurance pays for it, it's still very expensive for your insurance. And those are the things that drive healthcare costs up. In the US, dry needling really isn't covered by most insurances. And so we have people pay for it up front. And they'll pay anywhere from $25 to $50 per session, depending on how many needles. And so, again, you're asking someone to pay a lot of money for something that has, moderate to weak evidence. I'm not saying you shouldn't do it, but it's something. These are questions that when you're making your decision about choosing these interventions. Another question, I think, and this is a really important question, is am I spending so much time doing these unconventional things or things with low evidence that I'm not doing the things that have more evidence? So if I want to, if I do ultrasound on someone and they come back and they say that ultrasound really helped, well, then why not do it? It takes 8 minutes. It costs $10. Their insurance will pay for it. And then after I do that, then I'll have them do stretches and some exercises and functional activities. Then, yeah, that's fine. But if I spend the whole treatment doing ultrasound, dry needling, massage, vibration, cupping, and I never do the things that are important, like education and exercises, then you're on the wrong track. Um, and then the other thing that you have to ask yourself is are you being honest with the patient? Are you telling the patient being honest about the evidence? And I think it's important to you do have to tell them that it's going to be helpful, or why would you even do it? So you can say things like, my other patients really like the armband, or many people tell me that the wrist splint helps. But don't, you have to make sure you're honest and you don't say, everyone says that this helps or this always helps. You need to be honest about it. And I don't know are you familiar with the term snake oil? Is anybody familiar with that? It's kind of an American thing.
Never heard of it. Pregunta que si
Well,
saben lo que es el aceite de serpiente.
what it means is it means just a trickery that you're selling someone something that really doesn't have any value. I'm trying to think of an example of that. But it's really kind of being deceitful. You're selling people something that doesn't work. And so the thing is that people who do a lot of these things, that do a lot of vibration and do a lot of taping and stuff, they really believe in it. And people who say, I always give people the armband or I always do a lot of massage, they really believe that those things that are really helpful. And the thing is that all of us, everyone, are biased. And we have to realize that we're all biased. And we all tend to give more value to things that reinforce our strongly held beliefs. And then we also dismiss information that contradicts our beliefs. So I don't know if you've ever met someone and they say, I always do the armband. I give that to every patient. And if you gave them a study that said that the armband didn't help, they wouldn't listen to it because they know their deeply held belief is that it does. And it's true of all of us. So I think we just need to always step back and remember that we have bias. And also, people get better. We know that just through the natural course, people get better. So we might say, we did needling and we did stretches, and the person comes back and says they're better. Well, they might just be better through the natural course. So we attribute these things to the wrong thing. And just remember that they get better through the natural course. Also, the placebo effect is real. And if you tell a person that, the armband really helps or that the stretches really help, then that does increase their effectiveness. And I just think you have to be careful about not being deceitful, but also, I think, providing them, encouraging them to using the placebo effect to your benefit. One of the barriers for lateral epicondylitis, because you were asking, someone was asking, like, what's the best treatment? Well, the problem is that there aren't very many studies that study repetitive. So for repetitive use things, only about 6% of the studies covered repetitive use. So that's why we don't have good treatments, because people aren't really studying them. It's hard to study. And what you'll find that's very frustrating is that many of the studies, there's conflicting studies. The results are conflicting. Some studies say this works, some say this doesn't work. And some of the studies, the results are inconclusive. They work in the short term, but not the long term. And again, they're all nuanced. So you just have to take it back and look at your patient and apply it to your patient. Also, there are more studies on assessments, and there's less studies on treatments. And there are also fewer studies on exercise dosing. And I think that's a question that we all have is how much should they do it? How often? Once a day, 3 times a day, 3 sets of 15. There's not a lot of studies on that. And again, we said before, knowledge translation, it takes 17 years. But the problem is, after 17 years, many of those treatments are out of date, and the research is out of date. So I think the best thing that's happened for lateral epicondylitis is this document. And this is it's clinical practice guidelines, and it's published in the Journal of Sports and Physical Therapy. And that's how you can find it. And it's open access. It's in English, but you guys have lots of translation apps, and you know how to do it. It's very long. It's 111 pages, but don't let that worry you, because the summary is on page 2, and then there's a decision tree on page 40. And then at the end, there's tabs that you can click on, and it will tell you, you can click on armband, and it'll give you the evidence. It'll show you all the studies, and you can click on dry needling, and it'll give you the evidence. And it's just a great way so that you don't have to read a lot of articles and articles that conflict each other and try to decide which one is the valuable one. And that's the beauty of clinical practice guidelines. And it's also wonderful that these people, who worked for 10 years on this project, that the decision was made to publish it open access. And I think it's so important. And one of the, it's got a lot of takeaways. It's 111 pages long. But, one of the takeaways is to just kind of, instead of thinking about a person having lateral epicondylitis, think about what stage they're at, what stage of irritability that they are, whether they're at a stage of heightened irritability or not a lot of irritability. And also remember that it's not linear. It's not that they start with a lot of pain and then they get better. It's they have a lot of pain, they get better, then they have pain again, then they get better. And so wherever they are, you're going to treat them at that place. The study shows the different levels of evidence, so it's really easy to read. And I think this is probably the most important thing, and I've said this about 4 times so far in different slides. But what this study showed, the study that was 10 years, 111 pages long, what it shows is that there's no body of literature that strongly identifies a specific intervention. So again, there's not one go-to, and you have to use clinical judgment. Again, there's not a lot of studies that look at activity-based interventions. And so you remember the earlier slide where it said that 70% of these people are work-related injuries? So why aren't we instead of spending so much time on rubbing and needling and cupping. Why aren't we spending more time on looking at what they do at work and figuring out how we can change that? And tell me if you need to stop to translate or anything. Is everybody still here? Rosa?
Yes.
Oh, okay. Just want to make sure. Okay. So, oh. But one thing I think that we really need to take away from this is that we need a cultural shift where therapists are proud and feel a sense of accomplishment when they teach someone to do their job without hurting their elbow. And do you want to translate that?
Again, can you tell it a little bit
Okay.
slower?
So we need a shift in culture or a shift in our belief system
Okay.
so that therapists feel a sense of pride when they teach someone how to do their job without hurting their elbow.
Okay.
Instead of, because what are we all proud of? We're proud that we learned how to do taping, and we're proud that we learned how to do cupping, and we're proud that we're dry needling certified. We're all proud of that and think that's such an accomplishment. Well, maybe we need to learn how, we need to teach people how to do their job without hurting their elbow. That's what we should be proud to do.
Ahora, ok, Mary dice que debemos de hacer como un cambio en el chip, que en vez de decir yo soy muy bueno en hacer la terapia manual, el needling, el taping, en vez de eso, o sea, debemos de empezar a enseñarle al paciente cómo no lastimarse, o sea, qué modificaciones tiene que hacer en su trabajo para evitar las tendinitis, o sea, enfocarnos un poquito más en lo que es la prevención que el tratamiento de la lesión.
So I don't know if this is true in Central America, South America, but in the US, people like to get certified, advanced certifications.
Yeah, well, not here or not very much.
So people will say, I'm certified in kinesio tape.
Yes.
You
Es
you
que
can
dice que,
translate that. Or I'm certified in dry needling.
ajá, dice que en Estados Unidos sí es mucho de certificaciones y decir yo estoy certificada en esto y estoy. La realidad es que aquí, bueno, pasa mucho en México que muchas de las veces hay terapeutas que hacen ese tipo de técnicas y ni siquiera tienen una certificación previa porque se los enseñaron en un curso, se los enseñaron en la escuela. Entonces, aquí sí muchas veces no tienen el conocimiento o la certificación y aún así los terapeutas hacen las técnicas.
And a lot of times, those certifications, they'll make you take 3 or 4 courses, and they're multi-day courses, and they cost $1,000 each. And then after you take them, then you can get initials and you can put after your name, certified integrative dry needling, certified kinesio tape, certified manual therapy.
Sí, que muchas de
Take like
las
3 classes, but pay thousands of dollars, be certified.
sí, que son clases que cuestan muchos miles de dólares nada más para estar certificados y duran ciertos días y ya después de eso pues tú apareces como terapeuta certificado en alguna técnica.
But
Mari,
what happens when we do that is we believe that that's the one and only treatment.
¿Qué pasa? Que muchas de las veces cuando nosotros nos certificamos en una sola técnica, nosotros creemos que esa técnica es un todo para los tratamientos.
Have you ever heard the expression, if the only tool you have is a hammer, everything looks like a nail. Have you ever heard that expression?
Dice que si han escuchado la expresión que si tienes las herramientas, say that again,
Uh,
Mary.
if the only tool you have is a hammer, everything looks like a nail.
Que si solamente de las herramientas tú tienes un martillo, todo parece un clavo.
But it's part of what makes us bias is because we get so invested because we've spent so much money and we truly believe it that those interventions are the only way.
Ujú.
So I'm
Y
just saying, go ahead.
eso es porque muchas de las veces es eso, invertimos tanto tiempo en una sola técnica o en un solo tipo de terapia que nosotros creemos que esa es la única forma de tratar al paciente.
So I know you don't have the problem where you live as much as we do, but in the US, there's so much obesity. Everyone is so big and they have big bellies.
Ujú. Aquí en Estados Unidos no sabe si en Centroamérica, Latinoamérica, pero en Estados Unidos hay mucho problema de obesidad y tienen cuerpos o panzas muy grandes.
So if you have a big belly, then you have to be farther back
Ajá,
and reach farther.
ajá. Entonces dice que si tienes una panza muy grande, pues obviamente te queda más lejos el escritorio y tienes que hacer como más esfuerzo para estar en una posición de trabajo.
So wouldn't it be great if wouldn't you be a great therapist if you could teach someone how to stand or turn so they don't have to reach so far? Wouldn't that really be an accomplishment to be proud of?
Que sería mejor entonces enseñarle al paciente a modificar ciertas posiciones o posturas para evitar tanto esfuerzo en los miembros superiores.
And I think it's something that we really neglect in the treatment of these patients.
Y eso es algo que nos falta mucho en el tratamiento de los pacientes, trabajar en la prevención y en la modificación de lo que está causando el problema.
This is another great study. It's in English and it's in the Journal of Hand Therapy, and I'll send everyone a PDF of it. But it really talks about positions and particularly activities that cause it and ways that you can move while you do your job or while you play pickleball and not hurt your elbow. And this is what takes brains. This is why we went to school, more so than learning how to do a needle or cupping or whatever, figuring this stuff out.
De este artículo, Mary lo va a compartir los PDFs para que lo puedan leer y dice de cómo va en base a la función, la modificación y la ergonomía para el trabajo de este tipo de lesiones.
And here's the thing, all of this stuff has been studied. And all of these safe positions have been identified. And these are some sources online where they've identified the amount of force and different positions, in particular to lateral epicondylitis. So these are places that you can look. These two sites. Again, and this is from the previous study. Just thinking about the role of the wrist extensors. And, studies really show that the ECRB is the main tendon involved in lateral epicondylitis. And it actually is they call it the workhorse of the wrist. I don't know if you're familiar with that term, but it's really the primary workhorse, and it has tensions throughout the full range of elbow and wrist motion. One of the studies found that the ECRB is compressed by the ECRL when the elbow is in full extension. And the best position for lateral epicondylitis is the elbow at 90. And a safe range really is from 30 to 90. So when you're teaching a person, whether it's how to perform their job or play pickleball or whatever, just knowing those safe ranges.
Ok, este artículo nos habla de las posiciones seguras o los rangos de movimiento seguros que puede tener un paciente para evitar las lesiones y se habla que es de los 30 a los 90 grados y que evitar los últimos 30 grados porque es donde ocurren más lesiones, que casi siempre es la hiperextensión.
And you know what stretch? What stretch do we always have people do? This, right? You tell your patients to do that stretch?
No. I don't.
Well, but the problem, we shouldn't because we know when the elbow's in full extension, it's compressing the ECRB. So if we are going to have them do stretch, we should have them do it with their elbow bent a little bit.
Dice que cuando nosotros normalmente le enseñamos al paciente a hacer los estiramientos, el estiramiento es en esa posición de extensión con la flexión de la muñeca, entonces que sí se debe de hacer, pero con una ligera flexión a 30 grados para poder hacer la extensión sin comprimir el nervio.
And studies have identified what parameters people should have within their work to not hurt their elbow. You don't have to figure that out. Someone else already has. And then also again, neutral postures are so important. So if your fat belly has you back this far and reaching, that's not neutral posture. And neutral posture is neutral posture of all the joints. And the way when I went to school in Texas and people chew tobacco, and they spit when they chew tobacco. And they call this position, the way we remember it was spit in the cup. So it's the position you'd be in if you were holding a cup and you were spitting in it like that. But that's neutral position. So that's not complicated or hard to work with your patients in whatever activities they do and keep things in neutral position, and then they won't hurt their elbow.
Mario, una pregunta. Vos entonces decís que la postura neutra sería la posición funcional.
She's asking if the neutral position for the elbow would be the resting position.
90.
Yeah.
Yeah. With a safe range of, 30 to 90, that's the safe range.
Sí, de 30 a 90 grados.
And flexion and extension in which grade?
La flexión sería de 30 a 90 grados y en extensión no a más de 30 grados.
Okay, thank you.
And again, these are the things that we have to use our brain for. And I think we need to make a shift where we value these treatments more than some of the other things that we're doing. Not that there's not a place for those. So again, the clinical practice guidelines, it was, this is from the clinical practice guidelines after they synthesized all the data. And so they're saying that they don't necessarily, the evidence doesn't necessarily support the use of these. They may be helpful in the short term. But again, use judgment. They're inexpensive. They're probably not going to hurt the patient. So why not try it? Why not? But I think if a patient comes back, if you give a patient the counterbalance strap and they come back and they say, I stopped wearing it, it didn't help me, it made me hurt, then you need to say, okay, we'll try something else. And what you don't need to say is, well, you need to keep doing it. You didn't try it long enough. Or you don't need to say, well, that patient won't follow my orders and do what I say. Um, just remember, you're going to try it. It doesn't help everyone. The evidence doesn't support it, but it's okay to try it. Um, Again, the idea is that it changes the origin. So if it puts pressure here, it kind of makes the muscle stop here instead of back at the on the tendon. It provides support. It can hinder the extensors from full contraction, and it can decrease wrist strength. So there's some evidence that it helps in the short term, but I think bottom line is, why not try it? Do you guys use taping for the elbow?
Yes, I think that's the most very common. Que si ustedes usan kinesio.
Again, it's not going to hurt anyone. It's cheap. It's practically free, right? With the small amount that we put on them. It takes us about 1 minute to put it on. It's really easy. And so why not? Why not do it? It's not going to hurt anyone. And also it stays on about 3 or 4 days. And so for 3 or 4 days, the patient can see it and they can feel it. And that is also helps the placebo effect. So why not? Why not do it? I put this picture here to just kind of show you all the different taping techniques. And I think the point is, if there was one taping technique that was the right technique that worked, we would learn that technique. We wouldn't see, 10 or 20 different techniques. So I don't think there is one right technique. You might think that yours is. You probably do. Um, but again, you should do the one that works for your patient. So again, the goals are just to decrease pain and promote healing. But the most important thing really is to identify and eliminate the aggravating factors. And that's the part that you really have to think about. And, keeping those neutral postures and to always, lift in supination. And again, there's a lot of different things in the literature, a lot of different things to try. And then in terms of the medical interventions, probably the most common are the corticosteroid injections. And there's good evidence that those work. There's some evidence for Botox. Do people where you live use platelet-rich plasma?
Yes, it's very new and common here.
Inexpensive?
Yes.
There's not a lot of evidence for it. And again, I know people who have it done who pay $1,000, $1,500, $2,000 for it, and there's not a lot of strong evidence for it. And again, I hope the providers are honest about the evidence for it before they have people spend that kind of money. I wouldn't do it. Again, that's my bias. Another thing that they do is this autologous blood injection, and that's where they draw your blood from somewhere else and inject it there. Again, there's not a strong body of evidence for that. Another thing that they do, it's called percutaneous tenotomy, and what they do is they'll go in and a lot of times they do that when they inject the corticosteroid in, but they'll go in and take the beveled end of a needle. Needles with injections are fatter than our dry needling ones because our dry needling ones are empty. But they have that beveled edge and they'll go in and inject the corticosteroid, but they'll also go in and do some micro trauma. And the reason they do that is to increase the blood, to stimulate blood supply and healing. So they'll go in and that's called needle tenotomy or fenestration. So one technique that people do, or good justification to try dry needling is you can go in with a dry needle and you can do that same pecking. They call it pecking or fenestration or pistoning, where they go in with the needle and create microtrauma. And I think, with the dry needling, why not try it? And definitely physicians, when they do injections, they go in and do that. Again, should you do ultrasound? And this is from the clinical practice guidelines. And so they're saying they don't recommend it as a standalone treatment. And I think hopefully no one is doing modalities as standalone treatments, that they're doing them only in preparation for other things. Is there evidence for ice? Very limited evidence for ice. One study found that they did ice and electrical stim TENS units at the same time, and they had some short-term pain relief. And you might say, well, what good is short-term relief for a problem? Why would I bother with that? But if you have a patient who's in a heightened irritability, it really hurts, then you do want to do some short-term pain relief so that you can move forward and do some exercises. So there is some benefit sometimes depending on what level of irritability that they are.
Mary, someone's asking how long you recommend using the kinesio tape.
I don't know if I have an answer to that. Do you?
Me neither. It depends on the patient. Realmente no hay un tiempo específico para usar el kinesio. Hay pacientes que desde el inicio no les funciona, hay pacientes que les funciona muy bien, entonces no hay un tiempo relativo para el uso del kinesio.
I think if it helps them, keep using it. You could teach people to do it themselves too.
Dice que si funcionan, lo sigan usando. Incluso tú puedes enseñar al paciente a él poder ponerse el kinesio si es necesario.
Again, not a lot of evidence for modalities, but there might be some good reasons to do them in the short term, particularly when a person is in that heightened state of irritability, but not for someone who just has occasional pain. Oh, here's something on kinesio tape. They did it 3 times for 1 week with no tension, improved. Anyway, there's not answers to these, and I think you have to individualize it to your patient. This was a study about eccentric exercises, and I don't know if you guys do that, but that's where they slowly lower, and then I guess if you were going to do purely eccentric, you'd push them back up. In this study, they had them do eccentric, concentric, and then isometric, where they held, and they found some benefits. But again, there are a lot of other studies that say isometric aren't any better than concentric or isometric or eccentric. So I think this is why the clinical practice guidelines are so good, because you're going to find a study that says that this is the one way to do it. But if you look at all the studies in todos, there is not one kind of exercise that's better than another, but exercise is good. Some people do proprioception training with the patient. And again, there may be a patient that'd be good for. And that might be your pickleball player who only hurts when they play pickleball. Then maybe you're going to work on really refined things for that patient. So people can have radial tunnel, and radial tunnel, of course, is real near the lateral epicondyle. And these are just some tests to kind of differentiate between lateral epicondyle and radial tunnel. But it's important to remember that radial tunnel is a disputed diagnosis because the only finding on radial tunnel is uh, pain. So there's not any other findings like it. There's no ultrasound or X-ray or anything. It's just pain. Medial epicondylitis, we see it less often, but of course the stretches and everything would just be the opposite. And again, use your clinical judgment. I think, the thing we really should be looking at is, the ergonomic education and looking at neutral postures and safe ranges and just all of these things, adapting tools. And you don't have to come up with all these things. There are resources out there, and I showed you in that slide before that were in that study. So moving on to de Quervain's.
Mary, I have a
Go ahead.
question.
Yeah.
I wonder if you have some experience using shock wave for epicondylitis.
What is it?
Shock wave.
I don't know what that is.
It's like ultrasound, but in too high frequency. Maybe I could search a picture and show you.
Okay. Will it come in the chat? Should I keep going?
Yes, she said she
Yeah.
will like send you
Oh,
what is
okay.
the shockwave treatment. It's something that we use here. Well, I actually use it here in the
Oh,
clinic.
okay.
It's like an ultrasound in a very high frequency
Oh, okay.
that helps to literally give a shock in the tendon.
Oh.
Yeah, so
Is it just ultrasound with electrical stim? Like my machine will do that, where you can do combo? Is that what it is?
no. It's because it's not exactly like an ultrasound. The machine has like a little bit of a metal spot that gives a shot in the,
Oh,
yeah, it's different.
yeah,
Uh,
I'd like to see it.
yeah, I can show you.
I was in Washington, D.C. for the International Federation of Societies of Hand Therapists. And one of the sessions, they were talking about green light therapy. I didn't go, but they were saying it cures everything. And I think it just goes to show you how we can go down a rabbit hole on things we believe in. And I think anytime you say to yourself that this cures something, you need to take a step back and realize that that's probably not the case.
Yeah.
So de Quervain's, again, another frustrating tendonitis, and another one that's likely to resolve on its own if we just change the activities. And it's, tenosynovitis in the first dorsal compartment of the tendons, the APL and the EPB. And the difference between a tenosynovitis and a tendonitis is the tenosynovitis would be, compressed underneath this is compressed underneath the extensor retinaculum. So a tenosynovitis is going to hurt with stretch, and a tendonitis is going to hurt with resisted activity. And that kind of makes sense. And so the provocative test for this, everyone knows that this one, and everyone calls this Finkelstein's, but actually this is not Finkelstein's. This test is actually Eckhoff's, and it's an active test where they grab their thumb and do ulnar deviation. And actually, what Finkelstein's is a passive test. So what you would do is have them, passively fall into ulnar deviation, and then you slowly flex the thumb, passively. And then as soon as it hurts, you stop. That's a positive test. And the reason I think that there's a difference, or the reason we need both, is if you just do ECOFs. I've asked people to do that, and I've had people say, I won't do it. And I don't know if you've ever had de Quervain's, but I have. And if I did this, it would hurt for the rest of the day. It would hurt for 2 days. I wouldn't do this. You couldn't pay me to do it because it really hurt. And so when I have someone sit at my table and they say it hurts here, and I'll say, do this, and they're like, I don't want to do it. It's going to hurt. I say, okay, because I get it. But then you might say, well, can I really say they had a positive ECOFs if I didn't do the test? So I think that's kind of the beauty of Finkelstein's, is you can do it without really hurting them, because you can just have them go into passive UD, and if that causes pain, then you stop and you say positive Finkelstein's. And if it doesn't, you can slowly add the thumb, and as soon as it starts to hurt, you can stop. And that would be a positive Finkelstein's. There's another new test. It's called the what? And that's wrist hyperflexion, thumb abduction. So they're holding their wrist in flexion and their thumb up like this. And it actually has better sensitivity and specificity than the other tests. It's kind of a newer test. Some contributing factors are texting, because we're in ulnar deviation and using our thumb, holding a suitcase. Of course, the symptoms are, pain and range of motion deficit. And the treatment is really just a splint. And you can tell them to take the splint off and do just some gentle wrist motion and some isolated ulnar deviation and isolated thumb flexion. But the treatment is really the splint. Women are more likely to get it than men. And 40% of the women who get it were postpartum. That's when I got it. And I was changing the baby's diapers, and it had that tape, and I would pinch and pull, and that just killed it. So I still had to change the diapers. I didn't get out of that. I still had to do that, but I just had to figure out a different way to do it where I didn't go into ulnar deviation and hurt my thumb. And some of the risk factors are the first baby, and if the baby is a little overdue, and also a high BMI. Studies show that it resolves a lot of times after lactation. And I always thought that de Quervain's was caused by hormonal changes in your body when you're pregnant, because you know how you have more laxity, joint laxity during pregnancy, but actually some studies have found that it's really more due to the mechanical stresses of caring for a baby. So you think about when you pick the baby up, you're in ulnar deviation and you're holding them, and even holding the bottle or changing the diapers, that it's really kind of the mechanical stress. But as far as treatment, there's really not evidence that they need therapy. And what they really need, what the evidence says is the best treatment is a corticosteroid injection, followed by 3 to 4 weeks of immobilization. And I would say that they do better with a custom thumb spica splint, because it needs to be form-based, because we want to block ulnar deviation. When we make a custom one, we're going to have them the CMC in a functional position of palmar abduction, and the eyepiece free, and of course the fingers are free, so they can use their hand and they can still write, they can still do everything. And the advantage of a nice custom one too is that it's hard, and so if they bump it into something, the splint will protect it. And so I would say to the doctors who refer patients to you, send them to us for a one-time visit, and I'm going to make them the splint, and I'm going to do education, and that's all they need. And there's really no evidence that they need ultrasound or stretching or any kind of rubbing. They just need the splint and education. Again, you know, the injection, the evidence shows that that's what helps, and that there's not a lot of value to having ongoing therapy. And there's Finkelstein's passive. This is just a thumb spica splint, pretty easy to make. Another tenosynovitis is called intersection syndrome. This is where you get de Quervain veins in that first dorsal compartment. And intersection syndrome is actually here where the muscle, the wrist extensors go, radial wrist extensors go underneath the thumb muscles. And I don't know if you see anybody with that, but they actually present, it looks like a little tennis ball, a little ball right there. You can't miss it. And some people say that it even makes a noise. It even squeaks sometimes. But the treatment for that is just a thumb splint and, you know, immobilization, and they don't need ongoing therapy. So another biggie that you probably see a lot of is trigger finger, and it's also called stenosing tenosynovitis. And it's usually at the A1 pulley, which is here, and the A1 pulley of the thumb is here, and it's, you know, thickening of the tendon, a nodule on the tendon. And usually when they make a fist, they don't feel it, but when they come back, then it gets caught, and they have to, when they pull it through, it's very painful. So, so what does the evidence say? The one study compared the corticosteroid injection alone and corticosteroid injection plus a splint, or just a splint. And what they found was there was no difference in the outcomes. So the recommendation was that they just do the splint because that's the least invasive thing. This is a study, and it's out of Canada. And in this study, they did just 3 visits of physical therapy. And that's 3 visits total, not 3 visits times 3 months, 3 visits. And in those 3 visits, they did some range of motion and soft tissue mobs. Well, sometimes when you see people with trigger finger, they come in and their fingers stiff because it hurt when they made a full fist. So they just didn't, and they have a stiff finger. And if they have a stiff finger, then you have to treat them. You know, you have to see them until you can get full passive range of motion. So they may need several visits for that, but many of them present and they don't have stiffness. And there's a little evidence that soft tissue mobs might help, but you can teach them to do that at home. You don't have to bring them in to do that. Just teach them to do that. So education and making them a splint. And what they found was that 22% of them resolved with just the therapy alone, and then another 48% resolved with the therapy and the corticosteroid injection, and only 12% went on to have surgery. I did a webinar with Dr. Lalonde, and he was talking about trigger finger, and he said, and stop me if you need to translate, or do you think it'll just be okay because on YouTube it'll translate? So, okay, so I'll just keep talking. But Dr. Lalonde said when people came to him for trigger finger, that he used to always treat them. He'd always give them an injection, or he'd send them for a splint or whatever. And then he said he really changed the way that he did it. And he said the reason that he did is because he got trigger finger himself. And he said it just went away. He said it took about a year, but it just went away. And he just was careful to not agitate it. And so he says to people, if you want me to give you an injection, I can, but you know, the injection's going to hurt. And it's pretty likely that this thing is just going to get better on its own. And you're not going to make it worse by not having any treatment. So he really kind of advocates for taking more of a wait and see approach. And I think that that's something we all need to think about, is that a lot of these things resolve on their own, and make sure that we're not over treating them. Because when we are, we're just really increasing the cost of healthcare, across the board. So again, as I said before, that the reason we need clinical practice guidelines is because the studies so many times are conflicting. So there are a lot of studies that say that the splint does help, and here's a study that says that splints don't help. Some studies say they do help. There's really not a lot of evidence for modalities of any kind. So I hope that you're not seeing these people and doing ultrasound or ionto or anything, because the evidence really isn't there that those conservative things are helpful. So which splint do you use? And again, the evidence is all over the place about which splint to use. So if you want to know which splint to use, it's really easy. You just see which one works for your patient. So if you're thinking about, for me, my first order is the MCP. So I'll hold the MCP in extension, and I'll have them make a fist 10 times. And if they don't trigger, then that's the splint that I choose. And I usually just make this one. It's real easy to make. You put it on like that. Now, the advantage, and this is my opinion, because the studies don't say one joint or one splint is better than the other. But the advantage of this is if you hold your MP, one of your MPs in extension, you can make a fist, you can fully flex all the other digits and all the other joints. And that's because the muscle that you're immobilizing is the lumbricals, and the lumbricals is not a quadriga muscle. But if you immobilize the PIP, so hold your PIP straight, one PIP straight, and then try to make a fist with the other fingers, you can't fully flex the other fingers because you're blocking out part of the profundus, and that's a quadriga muscle. So you could spend all day with this on and it not be in the way, and you're moving your fingers. But if you choose one that immobilizes the PIP, then it's going to be in the way more because you can't fully flex the other fingers. So that's why this is my go-to. So if I do this one and they still trigger, then that one's not going to work. So then I'll try this one. And if they don't trigger, then that's the one that I have to use. Now, many people only trigger at night. And I always scratch my head why you would only trigger at night, because the only way that you trigger is when you're actively making a fist. So when they're sleeping, they must be making a fist. But a lot of people will say it only triggers at night. So if you only trigger at night, it doesn't matter which joint you mobilize because you're not using your hand anyway. And the advantage of these, oval 8 splints is they're very inexpensive. They're not custom. They're maybe $15. I actually 3D printed this one for like 1 penny. So if they're just going to sleep in it, why not do the PIP? But if they're going to use it, the MP, in my opinion, gets in the way less. There were also some studies that said relative motion splint is effective for trigger finger. So the way you know that if it's going to work for your patient is the pencil test. So, and again, it's going to be in more extension because you're trying to block it. Have them make a fist 10 times. If they don't trigger, if that keeps them from triggering, then do the relative motion. You don't need to have to worry about what the evidence says. Try it on your patient. Do the one that works for the patient in front of you. Use your clinical judgment. This is a patient education, flip chart that we use a lot, and I like it because it shows I think it's a real good way to understand the pulley system. And you can see here that's the A1 pulley, and it's small. A2 pulley's big, and A4 is big. And where the knot gets caught, there's a picture of it, is on that A1 pulley. And the surgical treatment for it is they just cut that pulley. And this is a pretty good picture. I can't remember where I got it, so I'm not able to attribute it. So I apologize for that. But it's really good because it shows that A1 pulley and the knot, and that knot is proximal to the pulley. So when you're making a fist, it's proximal. And then when you straighten, that knot's got to come back through and it's painful. And sometimes the knot gets so big that they can't straighten it. And this is kind of a surgical picture of the nodule, the stenosing nodule, and getting caught on the pulley. So this study showed that there were good outcomes with immobilizing the MP joint. And again, my bias, I like this splint. This is kind of my go-to splint, but you have to see the one that works best for your patient. Again, the studies are all over the place in terms of which splint to use and which joint to immobilize. Some say the PIP is better. Some says wearing the orthosis, regardless of which joint is blocked, causes a reduction in pain in the stenosing scales. And again, all the evidence shows that it doesn't matter which, they're not making a recommendation on which joint to immobilize or which splint, but the important thing is that you immobilize it for 6 to 10 weeks. And these are the stenosing scale, and I think this is really helpful, and it's helpful to explain to patients. So normal, obviously, and then the painful nodule. So sometimes they don't catch, but you can feel a little nodule. And then stage 3 is when it triggers. So they make a fist, they come up, and they feel that popping, but they come up. Stage 4 is they make a fist and it's sort of locked in flexion, but they can actively extend out of it. And then stage 5 is where it locks in flexion and they can't actively come out of it and they have to passively take it out. And then stage 6 is where it's stuck in flexion. And I've had people referred to me for a stiff finger, not the diagnosis of trigger finger. And I work with them and I get it supple, I get full passive range of motion. And then as soon as I tell them to make a fist, they trigger. And I know then the reason why they got stiff was because of trigger finger. And here's my favorite splint. I'm biased. Do you guys see people after Dupuytren's release?
Yes. And it's basically like very important after the release the therapy here. Mary pregunta que si ustedes ven pacientes con liberaciones de Dupuytren.
Again, the evidence is all over the place about the best treatment, whether they should do a limited fasciotomy or they should do the collagenase injection in cord rupture. And the collagenase injection is Xiaflex. Do your doctors use Xiaflex?
What is that, Mary?
So it's a collagenase injection, and the trade name is Xiaflex, and they inject the tissue, and then they wait like 2 days, and then they have the person come back in and they rupture those cords, those Dupuytren's cords. Are they not doing that very much where you live?
No, actually never heard of that here.
That's interesting. It's expensive. The injection is expensive. And actually the evidence is not, is all over the place on which is better, the limited fasciectomy where they go and cut it out or the collagenase injection with cord rupture. And again, it's more expensive. The advantage of the injection in the cord ruptures that can be done in the physician's office. It doesn't have to be done as a sterile technique. And again, the evidence is all over the place on that. Another thing they do is they can do this percutaneous fasciotomy. And you know, the needle has that beveled edge. It's really sharp beveled edge. And they go in with a larger needle in the office and they can just go in a single hole and just kind of saw that, the tissue like that. And I think there's more evidence that those tend to come back, but it's definitely the least invasive. There's not a lot of evidence about whether people should, whether they need a splint post-op or how long they should wear the splint or if they need hand therapy. And I think it would really depend on the patient. So Rosa said she sees these people.
Yeah, I start treatment after the surgery or the release, and most of the splinting is nighttime.
For
That's
how long?
doing for 2 to 4 weeks.
And
Only
again,
nighttime.
I think it depends on the patient. And if a
Yes.
patient, after 2 to 4 weeks, if you started seeing them come back down, then maybe you'd do it longer. You have to personalize it.
Ujú. Mary dice que si nosotros vemos a los pacientes después de las liberaciones, entonces yo le comento que aquí sí, nosotros los vemos después de la liberación, pero que el uso de la férula es solamente nocturno y que es de 2 a 4 semanas dependiendo de la evolución del paciente.
And these are just some clinical practice guidelines out of Holland, and you can just kind of read them. But they're saying that they all need exercise, but that it can be done through a home exercise program. So you don't necessarily need to see them a couple times a week, depending on how they're doing. And I think it's time we started thinking about that instead of saying they should always come twice a week for ever how many weeks. We should just kind of see how they're doing. And if they're not doing well, see them more often. And if they're doing okay, then see them less often. But those are the guidelines. So do they need a splint post-op or not? And again, this is from the Dutch clinical practice guidelines. And I'll just let you read those.
You want me to read it?
Or they can just read it.
Yeah, it's okay. Que pueden leer. Aquí es como el por qué usar o no usar la férula en el posoperado de Dupuytren.
Okay. Let's see. We have about an hour.
¿Alguien hasta ahorita tiene alguna duda?
Hola, sí. Bueno, yo quisiera hacer un comentario respecto a la imagen de la órtesis para el dedo en gatillo que bloquea la articulación metacarpo falángica, creo que es, para evitar la extensión, ¿no?
Es para
Bueno,
evitar la flexión completa.
ya. Bueno, en este tipo de casos, o sea, ¿cuán efectivo es la movilización o la inmovilización? Porque, bueno, he visto ya en muchos casos que ya, o sea, que sí consideran el tratamiento conservador, digamos, en este caso por la órtesis, pero dependiendo de las actividades de los pacientes, prefieren directamente hacerse una infiltración o creo que les hacen un corte, creo que es una microcirugía. Y en cuánto tiempo, digamos, nos ayudaría, digamos, el uso de la férula.
Mary, she's asking about the trigger finger splint. how long time do you recommend it and how effective this treatment is for patient that doesn't go through surgery?
So again, the studies are all over the place. So this one says, bring it up. This study, they wore it 6 to 10 weeks. And again, if someone only triggers at night, then they only need to wear it at night. I don't think there's a solid answer on that. Some of the studies say less often. I think you kind of have to judge it by the patient. This one says, again, this is a 6 to 10 weeks. So I think they would just wear it until they trigger less.
And do you believe the splint really works for the patients? She's asking like if it's really like the primary treatment for the trigger finger, the splinting.
So let's see, where is it? Yeah, so again, this study showed that the the patients did well, that they followed up for a year and that they did well with the splint only and the splint plus the corticosteroid and the corticosteroid only. So yeah, they do well.
Sí, dice Mary, bueno, este artículo viene como el porcentaje de los pacientes que les fue bien solamente con el tratamiento conservador y a lo mejor con la infiltración directa al tendón. Y yo creo que también depende mucho de el tipo de o el estadio en el que se encuentra el paciente, porque hay muchos pacientes que sí mejoran solo con el tratamiento conservador, el uso de la férula desde 4 a 6, 8 semanas, ya 2 semanas de manera nocturna les va muy bien y no llegan a cirugía, pero depende mucho del estadio en el que se encuentra el paciente, qué tanto tiempo lleva con el dedo en gatillo.
And I think this is a good study to just kind of show that when they did these things first, the 3 therapy visits, then the shot, then very few of them went on to have surgery. And like Dr. Lalonde said, it took about a year, but his got better without doing surgery. The advantage of the surgery, though, is so I'm going to tell you a story. The hand surgeon that I worked with, he was going to do a CMC arthroplasty, and I asked if I could come and see it. And when we were finished, I said, "What are you going to do next? I'll come and watch that." And he said, "I'm going to do an A1 pulley release." And I said, "Well, I'm going to run to the bathroom and I'll meet you in there." And he said, "If you go to the bathroom, you'll miss it." So we went in there and he just did this little bitty incision here. And he took like a crochet hook and he picked up the A1 pulley and he cut it. And then he did like 2 sutures and that's it. And they're never going to trigger again. It's fixed. And, Lalonde is saying, do this. You can do this in the office. You don't even need to go to surgery. So in some ways, even though I know the evidence says, I can wear the splint for 6 weeks or 10 weeks or whatever, that's kind of a hassle. Or you could go in there, and especially if it's bad, you can go in there and have that surgery that takes 5 minutes and you'll never trigger again. So I think it kind of depends on the patient. And especially if they have a big nodule or they've had it for a long time, maybe going straight to surgery is the thing.
I told them that it depends on how bad the patient goes. Sí, es lo mismo que dice Mary, depende mucho de en qué estadio llega el paciente y si ya realmente es un dedo en gatillo que está muy, muy grave y de mucho tiempo, es mejor que entren a cirugía directo, porque si muchas veces el uso de la férula y la terapia no les va a funcionar.
And there are different types of people, and some people might say, I don't want to mess with the splint. I just want this over with, do the surgery. And then there are some people who are like, I don't want to have surgery no matter what. I hate surgery. I don't want to have surgery. So I think it kind of depends on the
The
person.
patient, yeah.
Let me see if I can get to that other one. Okay.
Gracias, Mary.
Okay. Again, I think the answer is that there aren't answers to things. I think that's what I feel like what I've learned over time is we all want, I know I want an answer. I want to know how long to do this or whatever. And it's really comes back to clinical judgment. That's why
Yeah.
we went to school. That's why we're smart, right?
Yeah.
Yeah.
That's what I tell them, like to the people we teach, like in hand therapy, you will never have a patient that is similar to another. You will never have the same evolution, you will never have the same treatment, because sometimes a protocol will not work for another patient. So that's a lot of clinical eye and exploration, and have a lot of, like tools to work patients. So the more tools you have, the better treatments you can give.
And just being willing to change, instead of saying, no, I always give the armband. No, you need to keep wearing the armband because it really works.
Mhm.
Just saying it's not working. I need to try something else.
Ujú. Le decía a Mary que algo que se ha aprendido y que nosotros les enseñamos es que nunca vamos a tener un paciente de mano similar a otro, ni de miembro superior. Todos los pacientes son distintos, todos los pacientes evolucionan distintos. Lo que le funciona a un paciente puede no funcionarle a otro. Entonces, aquí entra mucho el ojo clínico, entra mucho el saber qué límites tengo, hasta dónde voy a llegar, y obviamente también el entender que entre más herramientas tengamos nosotros para trabajar a los pacientes, mejores resultados vamos a tener.
But I really like the discussions. And I think that's the great thing when you do in-person classes, because I feel like I learn a lot from other people too. So I'll come anytime you guys want. I'll come and teach a class, and then I'll do a lot of nice vacation stuff while I'm there and see beautiful things.
Yes.
Anytime. I love it. So we have about 45 minutes. I thought I might talk a little bit about fractures, if that's what people are interested in.
Dice Mary que tiene 45 minutos. ¿Quieren que hable un poquito de lo que son fracturas? ¿Alguien tiene alguna duda?
Hasta el momento todos los chicos están de acuerdo con que ella pueda hablar de fracturas, please, dicen. Sí.
Yes, Mary, they want you to talk about a little bit about fractures.
Okay. So something that we see a lot of are PIP dislocations and PIP ligament injuries. And we talked about before a lot about boutonniere, and that's an injury. And the injury from the boutonniere happens this way. They got hit this way. And when you get hit this way, the middle phalanx subluxes volarly, and that causes a boutonniere. Well, when you get hit this way, when the injury is this way, the middle phalanx subluxes dorsally, and the injury that you get from that, it's a volar plate injury of the volar plate, volar part of the PIP joint, and again, they get it when the P1 dislocates dorsal to the axis of the PIP. And this is kind of the standard protocol. And the idea is if you keep them in a little bit of PIP flexion, then that volar plate will scar down and heal, and they rarely need surgery. So we just put them in a splint, like a ring splint, and we have them blocked in about 30 degrees, and they can still flex all the way. So that's the great thing about this treatment, and it blocks out the extension, and that's the protocol, basically. So you can use these ovalate splints. They're about $12, $15 each. The disadvantage of these is that they you can't mold them because they're high temperature, and so they only have them straight. And remember, we want them in about -30. These silver ring splints are great. And the nice thing about them is you can bend them so you can change the amount of flexion that they're in. But they're expensive. They're like $100. And I just think like there's probably a person who's a jewelry maker who would make these for you at a reasonable price. Because, I go to Cancun and, on the beach, and there's always people walking down the beach selling silver stuff. And they'll sell you a nice silver bracelet for $15. They could make this for very little. So we need to find someone who would do that for us. But if you just injured your PIP joint and it's going to get better, then you don't want to invest $100 in this thing that you're only going to need for a couple weeks. So these are good, but you need to put something on the end of them to block it, so it'll be in a little more flexion. And I 3D print these, and again, it's really inexpensive. But the advantage of these is I can put them in hot water and I can bend it and I can have them blocked in little flexion.
Mary,
Sorry,
your
eh,
screen is
Rosa.
very.
Rosa, es que estamos en la diapositiva 38 nosotras,
Uh-huh.
pero a medias.
It says we are in the 38th, and like your screen, I don't know if it's frozen.
Oh, you know what I need to do? I need to stop sharing and start again.
Yes. And
Whenever I
start,
change a slide deck,
yes.
yeah.
Yes.
There we go.
See the splint.
So there's the protocol.
Uh-huh.
And then here's those ovalate splints, but again, you can't heat those up and change them. There's the silver one that you guys are going to find someone to make these at a reasonable price. I know there's someone out there. And then that's my 3D printed one, which I can heat up and make it block them. So this guy was playing some sport, and he had an injury and his finger went back like this. And so he goes to the emergency room. This guy was actually an occupational therapist, but he was not a hand therapist, but he was an occupational therapist. So his finger looks bad, right? Everyone would agree that it looks bad. See? Okay. Here's what it looks like in the x-ray.
Igualita.
Real bad. Did you think, like when you look at it this way, did you think it would be this bad? And I think
yes.
it goes to show you what they look like on the outside doesn't always tell you exactly what they look like on the inside. But again,
right now, my patient that is here, he had the same injury, but the doctor, the traumatologist, treated him 4 weeks with the metal splint without taking an X-ray in lateral to see was a luxation. So he needed a surgery. Look.
Oh, wow. Oh, wow. Gosh.
But it was the same injury.
Wow.
Mm-hmm.
So sometimes people could get this injury, and if it wasn't badly dislocated, what do people do when they hurt their finger? What do they do? They pull on it, right? That's sort of their idea. If it's jammed, they pull on it. And you could see if you did traction on it, you could reduce that dislocation. So I asked this guy, I said, "Did you try pulling on it?" And he said, "Yeah, I did." So this was so bad, he couldn't reduce it himself. But in the emergency room, they did reduce it. And so then he had therapy, and they made him, the dorsal blocking splint, and he did well.
Mhm.
So this guy, he was holding like a pipe, and he had a drill, and it had a brush on the end of it, and he was putting it in the drill, putting it in the pipe, and cleaning the inside of the pipe, and something caught, and his hand went back like that, so it was hyperextension. And look at that that
Okay.
raging swan neck, how bad that is. He's got his ring on. He's still in the emergency room. And you could see where it actually tore, the volar plate. But again, he was treated non-surgically. So he came to me, and I used this oval 8 splint, but I put a little bit of splinting material in the end of it here to have him in about 30 degrees of flexion. And it worked. So look how great he looks. He went from this to this, and he had a great outcome. Now, you might look at that PIP and say, his PIP's in little flexion, you need to work on getting that straighter. But you know what? It was so hyperextended that you're like, this is good. And we did work on straightening, but I didn't crank on it because I didn't want him to look like that. So the guy did great. So this is a real good protocol. Again, if you can get good treatment. And I'm sorry that your patient, and also that he was splinted straight like that when he should have been splinted in a little flexion. And the advantage of this is this splint, they can still move their hands so they don't get
Yeah.
stiff. But
If the doctor would took an X-ray in a lateral position, they would know the how bad the injury was, but they didn't. So they knew 4 weeks later, and he already had like a lot of stiffness, and the finger was huge. So the only treatment was the surgery.
so
It was
he was dislocated for 4 weeks.
for
Wow,
4 weeks.
I bet that was painful.
Yes.
Wow. Poor guy.
Ujú. Le comentaba a Mary que el paciente que veo ahorita, estuvo con esa luxación, la mismita que Mary mostró, por 4 semanas, solamente con una férula metálica. Entonces, el tratamiento que dice Mary de solo poner el anillo sí funciona cuando ese tipo de lesiones se trata desde un inicio, y solamente se tratan con el anillo para prevenir la extensión.
So they call this a swan neck disorder. I can't do it because my PIP doesn't want to hyperextend. That's swan neck, and it's the exact opposite of boutonniere. And remember, in boutonniere, what we were worried about was those lateral bands went volar to the plate, to the axis of the PIP. Well, in swan neck, they go dorsal, so they're up on top. And there are some people who can just do it. And I bet there are some people who are listening right now who can do it. And I'm not able to switch between videos very well in screen share, but you can look on YouTube and you can see, just Google swan neck and snapping. But if you look at this person, and this is just a regular person, she can just do this. Some people can. There's nothing wrong with her. She's fine. But you can even see those lateral bands on top. So you can see that the lateral bands have dislocated dorsally. And some people can just do it, and there's nothing wrong with them. You see it a lot of times with people who have arthritis. And so what happens when you make a fist is normally the way it works is you bend your MP and your PIP and your DIPs bend lastly. Well, because their lateral bands are on top, they're dislocated dorsally. When they start to make a fist, then there's resistance to flexion at the PIP, and they generate more and more force, and eventually they generate enough force for those lateral bands to go back down. And when they do, with a snapping, an abrupt snapping. And if we had an in-person class, I would have someone show you. But you can also just look at it on YouTube. Again, it's not going to hurt them. It's not a problem. Now, sometimes people will swan neck so much, and if you look on YouTube, you'll see this too, that their finger actually gets stuck and they have to passively flex it. And so for a person like that, they do need some kind of a splint if it gets stuck. And one of my patients said when she played piano, her finger would get stuck. And so for someone like that, who that's just how she's going to be, it's just her uniqueness. So she would definitely be a candidate to go ahead and buy the silver ring splint because she's not going to get better. That's just the way that she is. It's just what makes her special. She has joint laxity. So I had a patient and she had a bad injury and she ended up having swan neck and she really wasn't going to get better with the treatments that we had. And we gave her we ordered the silver ring splint for her. And she said that people complimented the splint and people said, "Oh, that's such a cute ring you have. I really like it." And so that's the nice thing about this is it's more appealing, cosmetically, the silver ring splint. We've just got to figure out a way to get the price, get a reasonable price on it. Sometimes people can develop a swan neck if they have a mallet that wasn't treated properly. And so she had a mallet injury and she had that extensor lag. And then you can see that she's starting to get some hyperextension here. And that's a good reason to, make sure that we treat mallets and try to get that full extension. There are also some programs on mallets fingers where they say post mallet injury that you would start them out in a splint that had the PIP and some flexion and the DIP and hyperextension. And again, that's just to not get that secondary swan neck. So this lady who had the mallet, this is how we treated her. And I put a little extra splinting material there so she would be flexed a little bit. But do you think that splint might be a little too tight? See the color of her finger?
Yeah, a little
Yeah.
bit.
We had to make some adjustments. That's okay.
I actually have a patient with that same problem. We have to the splint and she didn't use it anymore. In that finger, actually that same finger, the other two ones, because she had multiple finger injury. She uses in the third and fourth finger, but in the second one she cannot use it because it's too tight, and it caused more damage that good. And we had actually the same problem there. It's kind of funny though.
You know what I think too? Maybe in that injury, the vascular system's compromised from the injury because it went on and off and it didn't seem that tight. And it just makes me wonder if that vascular, if
Yeah,
they're
I
compromised.
actually thought that too because the splint was custom made from some kind of metal. She made it with a jeweler, and then
Wow.
it started to causing trouble, so we stopped using it. And it's actually she actually needed. I'm gonna suggest a few modifications to see, and a couple of studies if to see if circulation problem is the issue there.
Yeah. Because sometimes you think I've done everything. I feel like I've done everything right, and it still looks red. So there's a little more to it. And this we already talked about boutonniere, but this is just the opposite. And again, we talked about all of this already. Another pretty common injury that we see is that the ulnar collateral ligament of the MP. They call that skier's thumb or gamekeeper's thumb. And, when we describe things in the hand, we describe things as being radially and ulnarly. And so even though this is the thumb, this ligament's on the radial side of the thumb, that's the radial collateral ligament. This one's on the ulnar side of the thumb, and that's the ulnar collateral ligament. And that's the one that people injure. And you can see any kind of injury then that goes this way, like, holding a ski pole when you fall, is going to cause that to rupture. And if it's a partial tear, they can be treated conservatively with a splint and don't need surgery. But if it's a full tear, they need surgery. And I've had people sit at my desk and they'll tell you where it hurts, and you can see that the thumb's deviated. And I'll go like this, radially deviate it, and the thumb will just go as far as I would go. And then on that person, they probably need to have surgery. But if it's just sore and it doesn't go too far, then they'll do fine with a splint. And that's the protocol for the splint. And then usually we just make them a short opponent's splint. If it's just a real minor tear or sprain, you can do taping. And if you think about it, the problem isn't CMC abduction. They can do that as much as they want. That doesn't strain the ligament. The position that strains it is palmar abduction. Because when you do palmar abduction, then that's where it's going to be strained. So the taping here is just restrains the motion in palmar abduction. Metacarpal fractures, we see a ton of them. They do well. And typically we make them an ulnar gutter splint, and typically we do it forearm based. But the evidence is showing that if the fracture is more distal, then they don't necessarily need to have the wrist in it. They could have a hand-based ulnar gutter splint. And they can definitely have, the eyepiece free when they have that. We'll have the MP inflection. We want to have it in about 90 degrees, because we know if we splint them straight, they're going to be so stiff, it'll be almost impossible to get that motion. But again, I think using clinical judgment. So I had a kid, this child who was about 12 or so, and he had a metacarpal fracture, and it was distal. And I said to the father, I said, I can make him a hand-based, and I can also have it and have the eyepiece free. But I said, he's going to go out and think he can play football and he can climb on the monkey bars or whatever. And I said, I think we should go bigger for this kid, because he's not going to be careful. He's not going to watch it. And so I talked to the dad, and we ended up doing forearm based, and we ended up actually coming out to his fingertips, because I'm not worried about him getting stiff, because he'll be fine. I'm worried about him hurting it because he's a kid. But if I was your patient, then you would worry about me getting stiff. And so you would probably do less splint, because you're not worried about me going out and going skiing or playing ball or deciding to go swimming or whatever. So older people need less immobilization. We worry about them getting stiff. Younger people need more protection, and we don't worry about them being stiff. The most common fracture of the hand is the distal phalanx. And of those fingers, which one do you think is most likely to get fractured? Distal phalanx. Anyone know?
The mid one?
The long one, yeah. And that makes a lot of sense. It's the one that's out there and gets caught on stuff. Most of the people I see are work comp injuries, and I see a lot of distal phalanx fractures and a lot of amputations too. But they do well. We do a tip protector. I'm going to skip over the pain stuff, because I feel like that's a whole other thing. And I just was going to say a couple things about distal radius fractures.
Hola. Bueno, yo tengo una consulta antes de que pasemos a las fracturas de muñeca. Eh, bueno, en esto de las fracturas en las falanges, la verdad, a mí me ha tocado ver casos y bueno, creo que todavía no sé cómo tratarlas. Tengo un caso un poco complejo porque a esta muchacha yo la vi a inicio después de que le hicieron la cirugía, pero ya tuvo una fractura en la falange eh, proximal y le pusieron un tornillo. Y bueno, ella porque vive en otra ciudad, se perdió y cuando supuestamente se hacía controles con el doctor por llamada, le decía que estaba súper bien y todo, pero ahora que ha regresado, yo la vi, no puede ni doblar ni extender. No sé si puedo compartir unas fotos, ya que el doctor me pidió que le haga una férula para que el dedo no esté en semiflexión, me pidió que le haga una extensión. Y bueno, yo en mi poco conocimiento sí le hice unas férulas, pero no sé si ayudarán y no sé si ella va a volver a entrar a cirugía nuevamente, porque no puede ni doblar ni extender el dedo de forma completa.
Oh, she's asking about a patient that had a surgery and the finger had a semiflexion. It was a proximal fracture. So the patient, she doesn't know if the patient is going through surgery again to extend, or if you can share what type of splint she should do. And I guess it would be like a progressive splint.
It's
Right.
stuck, the DIP's kind of stuck in flexion,
The proximal.
the PIP. Yeah, yeah. Um, there are a lot of things out there. I'll definitely have them sleep in something that puts them on a little bit of stretch.
Mhm.
And
Usar, Mary dice que hay pues una variedad que se puede usar, pero lo correcto sería usar algo que la ayude a dormir con el dedito en extensión. No sé si sabes sobre las férulas de neopreno, las bananas. Esas son muy buenas para trabajar la semiflexión en la rigidez de los pacientes. Si quieres, ahorita te puedo compartir un poquito más de esa ferulita.
Ok, sí, me gustaría, por favor, porque, bueno, la mamá es, uy, ya ha venido con que le han hecho mal la cirugía, que cómo es posible que otra vez estén hablando de cirugía, pero es que aparentemente no le han movido el dedo como deberían haberle movido, ¿no? Y eso es lo que pasa aquí, al menos en mi país, pues muy pocos conocen la especialidad de mano.
Claro, es común. Ahorita te paso el dato de las bananas.
Ya.
and I think it's important to remember too, if someone's minus 30, they're fine. You don't have to go all the way straight. If you get them to minus 30, they're okay. I would rather have a finger that looked like this than go through surgery.
Ujú. Dice Mary que si la flexión es menos de 30 grados, que no pasa nada mientras tenga buena función, a someterlo otra vez a una cirugía. Más o menos, ¿cuántos grados de flexión tiene la articulación, Daniela?
It'll be interesting to see, though, once you get the passive motion, if they can go there actively, because a lot of times they can't. They might have an extensor lag.
Ujú. Puede ser que también tengan una falta de extensor. Si no extiende, o sea, si tú haces la flexión y el paciente no extiende por sí solo, puede ser que no logres tampoco esa extensión porque no hay extensor, un extensor bueno que trabaje.
So, a real good splint for that during the day could be your relative motion flexion, because they can still use their hand, they can still work on flexion, but when you block that MP and a little bit of flexion, it actually facilitates IP extension, and it would help with that extensor lag too. So maybe at night, have them sleep in something that's going to stretch it. Then during the day, go to relative motion. Relative motion flexion.
por la noche usar una férula estática para extensión y durante el día usar la de movimiento relativo con el dedito que no extiende hacia abajo, que esa es la que nos ayudaría a extender durante el día con función.
Because Rosa, don't you see that too? Even if they're stuck like this for a long time, even once you get them straight, then they'll have that extensor lag. So those are a lot of good reasons to do relative motion.
Relative motion, yes.
Yeah. I guess just a few things. We just have a few more minutes just kind of to think about on distal radius fractures is that a lot of times after people have a distal radius fracture, they end up being ulnar positive. And what that means is that the ulna, because when the radius breaks, it actually, even when they fix it, it actually ends up being a little bit shorter. And if the radius is short, then the ulna is too long, and they can damage their TFCC and they can have a lot of pain. And do you see patients, distal radius fracture patients, and they all say it hurts on this side? And you're like, you broke your radius. Why does it hurt on this side? And it's probably because they ended up being a little ulnar positive even after they're fixed.
Mary, someone's asking, how would you manage with splinting a cane book injury?
For Kienbox,
Yes, canvas,
so
yeah.
they probably need surgery. They probably need that ulna shortened.
Ujú. Sí, dice que probablemente esos pacientes no son de férula, son de cirugía.
And these are some of the procedures to shorten the ulna, and they're all like they're bad. They're called salvage procedures. So just ways to kind of shorten the ulna. But I think if they have Kienbox, they probably end up doing they're going to shorten that ulna somehow to keep it from yeah. Okay, wait a minute. Kienbox is negative ulnar variance. I'm talking about positive ulnar variance, so I was saying exactly wrong. So with Kienbox, gosh, I'm just having a brain thing here. So Kienbox is when the ulna is too short. When the ulna is too long is when you get TFCC. Kienbox is when the ulna is too short. So I think probably just a splint. And sometimes they'll do some bone grafts. If they have avascular necrosis to the lunate, they'll do bone grafts to try to fix that. But yeah, Kienbox is negative ulnar variance, and positive ulnar variance is going to crush the TFCC, and that's when they need surgery. And you can see, like this radius, when it broke, see how it got so short? Because normally the ulna is a lot shorter, and then in this space is the TFCC. So you can see if it's too long, it's going to crush those structures on the ulnar side. But if it's negative, then it doesn't support the lunate, and you get avascular necrosis of the lunate.
And you will manage just with like a functional splint for the rest?
I think it would kind of be up to the doctor too to I think they would need a splint, but I think it would be kind of a surgical thing to fix it. I'm not sure if a splint would fix it.
Sí, dice que no está segura que una férula pueda hacer todo el soporte, que sí tendría que ser algo que ve el doctor y ver si es quirúrgico o no.
But these are ulnar impaction where the ulna is too long, and again the lunate is too short. And a lot of people have TFCC pain. It's kind of a wear and tear thing, just like the rotator cuff. And when they get degeneration of the TFCC, then the ligaments of the TFCC that are supposed to stabilize the distal radial ulnar joint become lax. And you can see how mine are lax and how it just, they call it the piano key test, but see my ulna is very prominent and you can just push down on it. It goes up and down. And it's actually called the carpal bones have fallen down. So when I push up on my pisiform, watch what happens. See how my ulna goes away? So I've got laxity of those ligaments, and that's what's caused it to fall down. But you know, the thing about me is if I sat at your table and you're like, oh my gosh, look at all that laxity she has, her TFCC is attenuated or stretched. What do we need to do? But here's the thing about it is I'm fine. You don't need to do anything. I have full motion and I don't have pain. And so just because you see there's some findings like this doesn't mean that you necessarily have to do it if the person's strength is fine and their motion is fine. And again, you know, if it's not broken, don't fix it. And always go back and look at the patient in front of you and see what their needs are and use clinical judgment.
Aquí habla sobre las lesiones del fibro triangular. Muchas de las veces podemos tener pacientes hiperlaxos, entonces no necesariamente esos pacientes necesitan alguna corrección, alguna férula o algún tratamiento, porque son 100% funcionales, no hay dolor, hay buen rango de movimiento, hay buena estabilidad de la mano, entonces si algo no está quebrado, no hay que repararlo.
So do we have any questions or anything?
¿Hay alguna pregunta?
Why are you working on a Saturday?
Oh, because I'm a workaholic.
Do you always work
I
on
was
Saturday?
working too, actually.
Seriously?
Yeah,
Where are
I
you?
just finished. I'm from Paraguay. I'm from the south, near
Oh,
Argentina.
yeah, I know where it is. I'm going to Argentina in October, and I was going to go to Uruguay. I wanted to go to Montevideo. So I'll be right where you.
Wow.
No, Paraguay. It's another country similar.
But they're close. Circa.
Uruguay.
Yeah, they're close. Yeah.
Sí, Mary va a compartir they're asking if there's a way you can share your presentation.
So what if I send it to you? Would
Yes.
that work? Okay. And because it's big, you know, they're in sections, but it's still big. So it'll probably be like an airdrop. So you'll have to download it.
Yes.
You know, the airdrops go away. And
Okay.
I'll send those links to those articles.
Si esas me las va a pasar a mí, yo las comparto con Vero o con Fide para que ella se encargue de compartirlas con ustedes.
And I put my email in the chat.
Ujú. Y de todos modos, Mary puso su mail en el chat para que cualquier cosa que quieran charlar ya un poquito más específico con ella, también la puedan contactar por ahí.
And I'm also on WhatsApp.
Y también en su WhatsApp. ¿Alguna pregunta? ¿Algún comentario que tengan?
No, todo bien. Muchísimas gracias.
Ok, yo les voy a poner aquí mi Instagram para la chica que preguntaba sobre la ferulita, creo que era Daniela, Patricia, para que puedan contactarme por ahí, para cualquier duda sobre esa férula. Listo. Entonces, ¿ya no hay dudas? I think we're cool, Mary.
Okay. Thank you. I hope I get to meet everyone sometime. I maybe have met some of you already.
Yes.
Okay.
Thank you, Mari. Thank you
Have
very
a good
much.
Saturday.
Mary.
Do
Bye.
something fun.
Mary, you are excellent.
Okay.
Have a great weekend,
Bye.
everyone. Feliz fin de semana a todos.
Bonito, sí. Acá en tu quijada no te agarras la quijada.
Fernanda, ¿estás ahí? ¿Detengo yo la grabación? Sí, ¿verdad?
No, hoy la detengo yo.
Ah, bueno.
Ahora va.
Entonces, cualquier duda también ahí tienen mi Instagram, chicos, por si se les ofrece algo. Nos vemos.